Hello, and welcome to this Clinical Care Options podcast. I'm your host, Petra Cravens. In this episode, we hear from Dr. Arun Jesudian from Weill Cornell Medicine and Dr. Mazen Noureddin from the Houston Methodist Research Institute as they discuss expert-informed clinical pathway for the multidisciplinary care of patients with metabolic dysfunction-associated steatohepatitis, or MASH, current and emerging therapeutics, and management optimization strategies. To obtain the companion slide sets and view other program activities, please visit the link in the show notes for this episode. Now let's get started and hear from Dr. Jesudian and Dr. Noureddin as they discuss the current state of MASH.
So, Mazen, I want to start us off by talking about some basics of pathophysiology of MASLD and MASH and how other conditions like obesity and diabetes and metabolic syndrome play a role. Could you give us some overview there?
Well, thanks, Arun. That's an important topic. And I always say the MASLD or MASH is probably the newcomer for metabolic syndrome. Indeed, a lot of people say that it should be included as one of them, and some people started already doing that. But the MASLD and MASH start with a process that start in multiple axes. The first one is increased food intake, which is very common nowadays, right? Obesity on the rise, there's increased calorie intake, and a lot of that goes to the liver and doesn't get processed as it's supposed to because of the excessive eating. The other one, we call it de novo lipogenesis, which is increased making the fat in the liver. The liver makes fat and process it, but in this disease, the underlying pathophysiology, there's excessive de novo lipogenesis. And finally, the increased delivery of free fatty acid from the adipose tissue. So this interplay leads to increase in the fat in the liver. Over time, many patients are okay, but some progress to another subsequent, more advanced liver disease, which is MASH, which is the advanced form that consists of steatohepatitis. And it's in addition to the fat, there's inflammation and cell injury that presents itself as ballooning. And those MASH patients also subsequently, some of them progress to more advanced form where you start getting scarring or fibrosis, and there are different stages that end with cirrhosis. So this is kind of a quick snapshot. There are multiple underlying pathophysiology, including growth of gut microbiome, inflammatory cytokines, fibrogenic pathways, and that interplay lead to the most common liver disease, which is MASLD and MASH.
Clearly, advanced fibrosis is the major risk factor for poor long-term outcomes in MASH. When you think about which patients are at risk of that advanced fibrosis, who do you think about in terms of other parts of their story?
You're right, Arun, and let me reemphasize and the point that you made eloquently. So fibrosis matters. Fibrosis is in the elephant in the room. And as you said, we found that starting at stage F2 fibrosis, or what we call it significant fibrosis and then advanced fibrosis, currently called at-risk MASH, which is basically the steatohepatitis plus fibrosis at stage 2 and higher, again, at-risk MASH. Those are the patients that they're going to progress to morbidity and mortality. And what I mean by morbidity is what we see with liver disease, the bad stuff, the ascites, hepatic encephalopathy, variceal bleed. And our key job as hepatologists, you and I, what we do every day is trying to identify these patients. Who are they? And back in the days when you and I were doing viral hepatitis, we still do, but not as much as before. We used to look at this screen and look at liver enzymes and the viral load. And what I tell my fellows or my colleagues in primary care endocrinology, I now look at comorbidities. Look how the patient look like, the body type, the phenotype, and all this. And I look first if they have type 2 diabetes, and this is one of the elephants in the room. because it has been associated with higher prevalence of MASLD, MASH, as well as fibrosis. In addition, and per our guidelines, two metabolic risk factors are very important factors. So one metabolic risk factor is important, and you add two in here, the risk increase for MASLD and MASH. And metabolic risk factors are well known, such as dyslipidemia, obesity, hypertension, and there's international criteria. And now these comorbidities are reflected in our guidelines. There are other diseases that we see them often associated with MASLD and MASH, including sleep apnea, for instance, thyroid problems, psoriasis. So all these diseases are part of this mix of MASLD and MASH. But since I mentioned those, Arun, and they are important, and you need to identify patients. Let's say there's a patient with type 2 diabetes, and you want to know if he has MASLD, MASH, or advanced fibrosis. Can you tell me now, like, what is the most updated recommendation guidelines, and if we are still using liver biopsy to find out where these patients are and if they have it or not?
Yeah, that's a great question. And as you mentioned, we have been in practice for a while, and we used to take care of a lot of viral hepatitis patients where back then our only option for assessing fibrosis was a liver biopsy. So it is a great test in that it is the gold standard for determining the presence and the severity of fibrosis. And in this case, when we talk about MASLD and MASH, also the presence and severity of steatohepatitis. Biopsy, although it is the gold standard, has some drawbacks. So it is invasive, obviously. There is some risk of complications. It's a quite expensive test, and you can get some variability in the sampling of a biopsy, and then you need a pathologist, and you're a bit limited in terms of the expertise of that pathologist in reading liver biopsies. So fortunately, we have come a long way since the old days of hepatitis C, and we do have accurate, non-invasive tests for assessing fibrosis. And by and large, when we take care of MASH and MASLD patients nowadays, our fibrosis assessment doesn't involve an invasive liver biopsy. So we can use serum-based tests, even straightforward ones that are accessible to primary care providers out there, like FIB4 or APRI-AST to platelet ratio index. There are some more specialized or commercial serum-based tests, and certainly we are using a lot of specialized imaging like elastography, ultrasound or MRI-based elastography. Those are some non-invasive options that can stage fibrosis for us without having to put the patient through a liver biopsy. And of those, do you have a preference in your practice, and or what would you suggest to, say, a primary care provider or a gastroenterologist out there who maybe doesn't have access to some of the more specialized non-invasive testing?
Yeah, sure. And as you just alluded, it sounds like we have a toolbox. So I guess let's talk about the clinical pathway for a second. That you and I, like now, when we get a call from gastroenterologists that they want to know the update about the guidelines, or endocrinologists or primary care physicians, we do have now multiple guidelines and documents telling us what to do. That will include the American Association for Study Liver Disease guidelines, the American Gastroenterology Association, American Diabetes Association, and American Association of Clinical Endocrinology. And not just those, I just mentioned those in the US, but the European Association for the Study of Liver Disease, the Latin American Association for Liver Disease, all of them, they have guidelines. The good part, or the good thing, is that they're all unified on what to do. So let's summarize it for a second, and I'll tell you which one I use. I'm interested also in what to use. But now, in a unified way, we're telling everyone, if you're a liver doctor's office, GI office, endocrine office, you need to start first with what's called the FIB4, which is a test that consist of ALT and AST agent platelet. You can go to Google and look it up. You can have an app that will look at these patients. And as we mentioned earlier, the type 2 diabetics or 2 metabolic risk factors, they need to go to this test. If the test is less than 1.3, the score, the patients will stay with the primary care. If it's between 1.3 to 2.67 or more than 2.67, either way, you need additional tests. And there are two things in the guidelines. The second test will be one, transient elastography, or something called the ELF score, which is a serum-based score. The transient elastography is an imaging-based test, can tell me the amount of fat, steatosis, and stiffness. And the ELF is serum-based test, which is fibrosis marker. Levels in the guidelines more than 7.7, more than that suggests referral, but the 9.8 progression to cirrhosis and more than 11.3 point toward progression to decompensation. So what I use in my office, usually the patients come to me, the FIB4, or sometimes the primary care forgets to do the FIB4 and they send it just based on steatosis. I kindly ask everyone to do that first, so to decrease the burden on us as well. And I do transient elastography often in my office, and we can talk about subsequent step, but I'm also wondering what's your intake on this algorithm? What do you use in your office, and do you use subsequent step beyond the transient elastography, and which kind of transient elastography numbers you look for, Arun?
Yeah, we are similar in our approach, and I think it's an important point that there's so many patients out there that it is helpful to have their primary care providers able to start that risk assessment with the FIB4 before they get referred over to a specialist. And so that's something that we've tried to implement here and have done so relatively successfully, that patients who have risk factors for MASLD or steatosis on imaging are getting a FIB4 calculated, and then that determines whether they're referred over to us. And like you, when they come to us, and particularly with a FIB4 that could be consistent with advanced fibrosis, we're also employing a lot of transient elastography, and in certain patients, some MRI elastography, particularly if there is another indication for the MRI in terms of, say, insurance coverage. So if they had a liver lesion that needs a bit more characterization, I found that is a situation where we could successfully get an MRI with the elastography and fat fraction and a great test. But the office-based elastography that we have certainly helps us determine, based on stiffness measurements and how high that kilopascal reading is, who should be considered for more aggressive therapy, who maybe needs screening for hepatocellular carcinoma, who we might refer for some type of bariatric procedure, for example. So I do, really endorse what you reviewed, which is an approach that allows us to divide patients into low risk or intermediate risk or high risk, and then get them to the appropriate provider who can help address those risks and really try and prevent them from progressing and perform any screening that they might need based on how advanced their fibrosis is, which kind of segues us into what treatments do these patients have available to them? And I know you're very knowledgeable about this. So if you wouldn't mind giving us a bit of an overview about treatment options for MASLD and MASH in the current day and age, and if you could talk about, if there are any efficacy or safety data when it comes to maybe looking forward, emerging treatments.
Thank you, Arun. And I cannot agree more. Now we have really fancy, sophisticated tools in our office that can tell us where the patient at without doing liver biopsy. And we have been used that in our practice for management and therapies, right? You and I know we're just around the corner from hopefully first FDA approval for MASH. But let me tell you what we do today. And this is also driven by the AGA-ASLD guidance, American Association for Study Liver Disease, American Gastroenterology. So lifestyle modification is a key factor or a key component of the entire thing. But we should not forget this holistic approach, because this is a systemic disease that involves metabolic syndrome. So what we eat is a key. As you know, a lot of people eat excessive calories, excessive fat. And with the lifestyle intervention, there are different recommendations, such as Mediterranean diet has been shown to be very helpful in MASLD MASH, but also what we realize quickly is like we cannot impose a certain diet on multiple people. There are people from different cultures, different ethnic background, but the concept is the same: lower calorie, lower fat, or lower carb. And whatever works for the patient actually is good. Some people do intermittent fasting and they benefit from that, and there's emerging data on that. So all these things are helpful. But we also know that the type of food matters. So red meat has been associated, and especially the processed red meat has been associated with increased MASLD and MASH, as well as the cirrhosis with it. Fructose, or high corn syrup, which we see often in our drinks, sodas. So this is something we ask the patients to avoid it. There are good food that we recommend. We like coffee if there is no contraindication to coffee. We also like healthy food, especially high with fiber. So this is kind of the big category. And with the therapies or pharmacological agents, the new guidelines emphasize on treating comorbidities. So they don't necessarily recommend yet for NASH, but they say if you have patients with MASLD, MASH, and obesity and type 2 diabetes, please try to lose weight. The new guidelines are more liberal in terms of using products such as GLP-1 and trying to lose weight and exercise. So those are kind of what we're using today, and I'm happy to delve into what is in the pipeline. But let me stop here for a minute and ask you, Arun, is there anything you would like to add to that, or something you do differently in your practice? Because it's really an art how to help patients with their lifestyle intervention, and I would love to get your input on that.
Absolutely. It is an art. And I think you're right that most of us know, if you are reading about it or if you're thinking about how could we improve the level of steatosis and steatohepatitis, we know that lifestyle modification and weight loss and exercise all play such an important role. But how do you translate that into your patients actually being able to accomplish that is where some of the art gets introduced, I think. And for us, we try to tackle that in a multidisciplinary manner. So we have our patients see, for example, a dietitian who can help go through what they've been eating and what might be helpful dietary changes. Sometimes we're able to get patients into a supervised weight loss program or exercise program. Certainly, we're considering, just as you mentioned, pharmacotherapy when it comes to treatment of their comorbidities, their diabetes, their metabolic syndrome, and potentially their weight itself. GLP-1s are such a fantastic asset in that battle when it comes to being able to achieve weight loss and resolution of steatosis potentially. And then we certainly also talk to our patients about coexisting conditions. So some of these patients, although they predominantly have MASLD or MASH, might be drinking a bit too much alcohol. So they might have more of what we now refer to as MetALD. So they might have a combination of the two. So we can't forget to talk to them about modulating their risk even outside of the traditional metabolic syndrome risk factors. It is relatively labor intensive, as you know, but it is really important to educate patients and to try and tackle each of these portions of their lifestyle, the contributors to their MASLD and MASH, so we can accomplish, hopefully, resolution of the steatosis and maybe even improvement in the steatohepatitis. that is clearly an unmet need at present. And so I'm excited to hear you talk about what we may expect in the future in terms of FDA-approved therapies for MASH. And if you could give us a bit of insight into how the efficacy looks for some of the agents that are out there and what the safety looks like.
Yeah, Arun, thank you so much. And although this lifestyle modification education is one of our main tasks, unfortunately, not all patients achieve that. And this is a known fact, including with the GLP-1s and other medications. So we have to put more into it. And what I tell the primary care and endocrine out there, yes, please help us and support us, but also don't ignore the fact that the patients sometimes do not respond. And more importantly, many are progressing. And when they get to the advanced fibrosis or closer to cirrhosis, I call that the cliff. So you want to grab the patient before they slide there and disasters happen, which, the decompensated cirrhosis. So if things are not working or the patient's already there, hepatologist needs to involve. And guess what? We are just around the corner, hopefully from FDA approval. And to kind of give you an idea about the landscape, I'm going to mention the phase 3 drugs in general. If we talk about the F2s, phase 2 drugs, it's probably an hour conversation, which we will refer you guys to other references and review papers. But let me start with resmetirom. Resmetirom is the drug that is waiting for the FDA approval. Resmetirom is a thyroid hormone beta receptor agonist. And these thyroid hormone receptors are in the liver, which something we have learned in the last decade or so. And what they do, they regulate the glucose and lipid metabolism. And what resmetirom shown that it decreases the fat inflammation as well as fibrosis in the liver. So fast forward, after almost a decade of trials, the drug now has shown in a phase 3 that it improves the two primary endpoints that the FDA asked for. They asked for one of them. So resmetirom had both of them, which is what we call NASH resolution, and without fibrosis worsening. So the NASH is improving, and the other one, fibrosis improvement, meaning if you have advanced fibrosis, you go to less severe, let's say significant fibrosis. So they hit both in around 25 to 30% of people. Again, this is not low efficacy, it's just the bar is too high with histology, and we're hoping for soon FDA approval. The other drug that is ongoing, their phase 3 trial, semaglutide, which is familiar to many people because it's approved for indications for type 2 diabetes and obesity. And in a phase 2 paper published in the New England Journal, they have shown that in a histological study, they also tried semaglutide and it achieved NASH resolution. It did not hit fibrosis improvement. There are multiple reasons for that. Maybe the duration, maybe high placebo response. Either way, the phase 3 is ongoing. If they hit what they hit on the phase 2, they will get approval. But we're hoping also they will hit the two endpoints, including fibrosis improvement. The third drug will be in the phase 3 lanifibranor, which is a pan-PPAR receptor agonist. And what it does is also, like, these receptors regulate glucose and lipid metabolism. And this drug has also published in the New England Journal in phase 2, where it showed both NASH resolution, fibrosis improvement, and the phase 3 is ongoing. The other class of drugs, I want to mention something called FGF21 agonists. So those are receptors that they play intimate role in the gut as well as the liver. They regulate gut lipid and glucose metabolism. They play a role in inflammation as well as fibrosis. I'm going to mention too efruxifermin and pegozafermin, that they are now entering their phase 3. Their studies have been published in the New England Journal for pegozafermin and efruxifermin, in the Lancet Gastroenterology and Hepatology, also showing histological benefits, and we are waiting for their phase 3 studies. as you heard, is there are many in the pipeline for phase 3. There are many others in the phase 2, and I think we have a topic on that specifically in this series. But the future is bright. Hopefully, we have a drug approval soon. We're all expecting it, but we shall see. And in addition to the holistic approach, we want to make sure we prevent the patients from downsliding that cliff and getting to cirrhosis as well as decompensation cirrhosis. So this is a snapshot, Arun. What's your thoughts on those?
Yeah, I'm really looking forward to having some therapies available for those patients who I see who maybe they have stage 3 fibrosis, and we have maximized what we think we can accomplish in terms of their lifestyle. And that is clearly a patient, just as you mentioned, who is kind of on the cliff, if not quite at the edge of the cliff, approaching that. Although part of my practice is taking care of patients who need liver transplants, I would love to avoid that in its entirety, cirrhosis and complications of chronic liver disease. So for those patients, I'm excited to hear what you laid out as really promising outlook on therapies that could help us reverse steatohepatitis and potentially stop or regress fibrosis. And just on that subject, I was curious, you mentioned there might be various reasons why it's difficult to meet that fibrosis regression endpoint. Do you think it is that we don't wait long enough in these trials, that the trials are designed where that assessment is made too early, or do you think it is, that the placebo is pretty effective, so it's difficult to make a statistically significant improvement there?
Yeah, I think, and I don't want to go too deep in our regulatory pathways, but the first point is the fibrosis improvement and the requirement of not having NASH worsening by the regulator. So they make it a bit harder there, and I don't want to go into too many details. I mean, if you improve fibrosis and the NASH gets a little bit worse, it could be biopsy reading variability. So we question that all the time. You're right. The more severe the fibrosis, the harder it is to reverse. Meaning, if you have cirrhosis, it will take me more potent drug plus longer duration to reverse that. And sometimes they don't wait enough in the trials. This is chronic disease that has been evolving over 10, 20 years, and now we want to try to reverse it between a year or two, and even sometimes they try 6 months. But we're starting seeing good signals, Arun. We're seeing even fibrosis improvement, and there are data coming. There was recent announcement that cirrhotic started reversing a little bit. So those are all exciting. I really look into 2024 and beyond. I think we're in a much better place after a struggle for a decade. And I think the door is just gonna open up for our patients and us as a providers, give us satisfaction in helping these patients at most unmet need. So yeah, that's NASH in a snapshot, Arun. I don't have final comments. I wonder if you have any final comments, but it was great to be here.
Thank you. And the only final comment I'll say is that I am as happy as you are that we're going to have better options for our patients. And I think we should all expect large numbers of them to find their way into our offices. And I think on the whole, that's a great thing because it's such a public health threat, metabolic syndrome, and particularly in terms of the liver, MASLD, and MASH. So thank you for your thoughts.
Thank you, and glad to be here.
I'd like to thank Dr. Jesudian and Dr. Noureddin for that excellent discussion, and thank you, our listeners, for joining in. As a reminder, to view the full program on Clinical Pathways' multidisciplinary approach to managing metabolic dysfunction-associated steatohepatitis, which includes 4 text modules with accompanying slide sets, clinical thought commentaries, and a MASH Clinical Pathways downloadable infographic resource. Visit clinicaloptions.com or click on the links in the show notes for this episode. Thank you.